them over to the side. We will definitely be taking questions from the audience if you guys would prefer to do it that way. And I have some backups if we need that as well. Okay, so just as like an introduction, I'm Nisha Hakhu. I am, first of all, a mom of Talia. She's 7 years old. She is absolutely hilarious and has so much energy. And she has a Grin2B mutation, likely loss of function, ADHD, intellectual disability, sensory processing, dysphagia, feeding issues, and super bad constipation. So that's her in a nutshell. I'm okay? Okay. So I'm also a pediatrician in the Chicagoland area, and even prior to the birth of my daughter, sort of had the privilege of working with some of our more medically complex children. But really being a mom has taught me so much, and I continue to learn and grow through this community and the whole Grin community. So that's been really amazing. So I have I'm really excited to introduce our specialists today. I have two amazing people next to me. This is Ryan Geslani. He's an occupational therapist. He studied at Boston University, and he's been practicing pediatric OT for over 20 years. He also has a personal history of narcolepsy, and he's the father of a now 13-year-old amazingly beautiful girl with a rare genetic disorder. She has a genetic disorder called GABRA1. It's so interesting because our kiddos have the Grin mutation, which is for the glutamate neurotransmitter, and his daughter has a GABA receptor mutation, and glutamate and GABA sort of work hand in hand and sort of opposite. So we've known each other since I think before we had either of our children, and we've worked together professionally and sort of over time sort of lived these parallel lives. So I think that Ryan has a lot of really good insight personally and professionally to share with you. And then to the right of him is Dr. Innessa Donskoy. She did her training at UIC Chicago, and then her residency fellowship at Northwestern and Lurie's in sleep medicine. She's a board-certified sleep medicine physician. She's also, first and foremost, the mom of 3 beautiful young children, and who I'm sure have had sleep issues in the past, and I'm sure she doesn't get very much sleep also. So I will leave it up to questions. Were there any cards? Oh, okay, there we go. Thank you. Excellent. So, Pat, stick around. You're going to be taking the mic to people. Okay. Our biggest issue is hyperactivity at bedtime. Our daughter seems to be getting more hyper when she should be winding down. Any suggestions?
Well,
so hi everyone. Can everyone hear me? So this is actually a very, very common thing that I hear, and actually a very physiologic, very normal thing that happens. What's pretty amazing is that our sleep is really controlled by something called our circadian rhythm. There's a part of our brain in our hypothalamus that is essentially our internal clock, this timekeeper for us that tells us when in the 24-hour day any of us, our children, ourselves, are most likely to wake up. And then about usually 7 to 9 hours later, have a dip actually in our energy. Many times this will be like a lull, late afternoon. Some cultures actually really embrace this and have napping or siesta time. Our culture seems to encourage caffeination and powering through. But it's actually very normal to have that dip, and then following that dip, very, very normal to have an uptick in energy. And a lot of times this is going to be a lot of excess activity nearing bedtime, things that make us feel nervous. Gosh, why aren't our kids getting tired when we're exhausted from our day? But it's actually a very physiologic reaction that happens after that lull. So we don't actually have to fight it. We can really lean into it. We can sort of encourage physical activities that are a little bit more relaxing, and yet really engaging and fun at the same time. And then that is sort of going to lead us into really that circadian cue of, okay, no, now I'm ready for sleep. That comes a little bit closer, about 2 hour or two closer to bedtime, when our natural melatonin is kicking in. So this up and down pattern, if we really fight it, then we end up with challenges. But if we lean into it and just pick on our own, right, or hand in hand with our child, certain activities that both of us see a benefit to, we can really help them calm into when they're ready for sleep.
I love that. That's really, really interesting, because I would probably sort of the same thing, from an OT perspective. We always talk about heavy pressure, deep pressure, and those are probably those activities that you probably would be talking about doing. So, and those are really individual too. It's really like reading your child and, creating routines. I think that those are the most thing that you should probably look at and study, and then really stick with it. I think some people are always so quick to give up on things that were suggested to them. I would really just, again, lean into those things. Figure out, like, if your child loves that deep pressure squeezing, try to find different ways to do that. Get some bean bags, pillows, just give them those nice tight squeezes. Some people will, again, this may sound counterintuitive, but others may love spinning, but sometimes that's also very, very calming to them. So again, it's about reading your child, I think, is those things to really do. And I know everyone's so concerned about keeping a time. You need to be at this time, but again, I think it's about finding what works for you, for the child, and for just your overall routines.
Absolutely, that was so beautifully said. And also reading how that day went. Was it a day with a lot of physical activity? Was it a day with a lot of output?
Yeah.
Perhaps then, we can be a little bit firmer around, we get tired and we should do bedtime around this time.
Yeah.
Was it a day of hanging out, just kind of chilling as a family, being pretty sedentary, not doing much, waking up a little later that day?
Mhm.
Perhaps our bedtime needs to shift slightly to sort of accommodate everything we've done that day.
Yeah.
That flexibility is really important too.
Mhm.
Awesome. I have 2 questions that are somewhat similar, so I'll combine them. So one of them says, my son talks and talks and talks at bedtime, and sometimes it takes over an hour to fall asleep. And the other one is similar, struggling with bedtime because of talking and stimming. Takes a long time to fall asleep, and then sometimes waking up in the middle of the night, or like 3, 4 a.m., stimming and talking at the same time.
That's interesting. I don't know if I've really had that happen.
Well, so we have to be, if you think about what we need to fall asleep, each and every one of us, we need to be really relaxed and calm, right? We can't be anxious. We can't be overwhelmed. We can't have things on our mind. But inevitably, when the lights go off and everyone walks out of the room and we're alone or our child is alone, that's when those anxieties and fears and ideas and sort of impulses come up. So I actually really love recommending something called, I usually call it like scheduled processing time, or sometimes I'll refer to it as like scheduled worry time. We could also call it like scheduled activity time. There are thoughts and feelings and sort of impulses that we can't just erase. We can't take away, right? Our kids can't either. And so what I like to do instead is just find a different time in the day that those feelings and thoughts and movements can go intentionally. And I often encourage parents to schedule a time, a short amount of time, 5, 10, 15 minutes a day, but a reliable time, a time that their child knows, okay, every day at 4:15, I get to tell mom everything I was thinking about that day. Or I get to like sketch or kind of scribble on my coloring pad while we schmooze. Or I get to kind of have bouncing, jumping, moving time. This is a little bit why therapy works, right? It's sort of this reliable place to get it all off your chest, to get it off your mind. Because we can't really suppress it, and our children can't either, so we just need to give them a sort of a reliable place to put those ideas and emotions and feelings and impulses. And again, like, it's all about leaning into
Yeah.
it. The harder we fight against certain things, the more they're going to crop up. And then when we're falling asleep, you know, anxious and having wanted to talk about something or get it off our chest or move, our arousal threshold is going to be lower throughout the night if we're falling asleep stressed. And we probably are going to wake up in the middle of the night wanting to talk again or move again. So really incorporating that earlier in the day.
Yeah. I mean, yeah. Go ahead.
Just to follow up on that, I don't know about other families here, but from my son, that problem has been since he's an infant. So I don't know what stress or anxiety they would have. And it seems that the stimming, the waking up in the middle of the night and babbling a lot and talking to himself and moving and stuff was a regular thing up until, well, it still happens. It happened every night until he was about 3 years old, and now it happens every few weeks or so. So I don't, like, is that related to anxiety and movement, or is there something else neurological going on that we can perhaps treat with, like, medication?
What do you think made it better? What do you think made it less frequent?
Reduce? I don't know. We've been using behavioral modifications since he's 7 months old, and it didn't actually clear, like, it didn't clear up till he was 3 years old. And that was with consistent, like you said, relaxing at bedtime, having that routine, getting the circadian rhythm really set. But he still wakes up once in a while in the middle of the night, and we were doing a journal to see if there's any link, and there's nothing in terms of food, his schedule, like, we can't seem to find any kind of pattern.
I mean, it sounds 3. It sounds like it's just things are just maturing a lot. So.
But I think it's
Yeah.
everything that you're
Yeah, so
doing
yeah.
as well,
Yeah.
right? And so what I hear is that all of the techniques you've been doing since infancy, now that he also has matured, they're starting to click. They're starting to click together. And that's a really long time. I think it's amazing that you're keeping up at it and it's decreasing. But I think when I say the word like stress or anxiety, we think of it as, gosh, what are they worried about, right? But that's not exactly what stress is. We have stresses all the time. I had stress, you know, coming here today because I was excited, right? Or maybe you had stress the night before your wedding, right? Or maybe we do have some kind of stresses when things aren't going well in our lives. Things can be very big or very minor, but they can change the way that our brain is processing what's going on. Sometimes what is a stress to me is not at all a stress to you, right? And so sometimes we don't actually understand what is the stress right now to our child. Is it a positive or negative stress too? So I think there's multiple layers to it, but like you've been doing, those behavioral opportunities to let him get the movement out in the day are really, really, really key. And you mentioned earlier also about finding ways to kind of provide sensory input to the body that's not through movement, right? And that's through sensory input. So massage, squeezing, dry brushing. Sometimes you can almost mimic what the body's trying to do by movement when you provide that sensory input for them. So I would keep doing the amazing things that you're doing. There are always other things to think about as well.
Is
Right?
he verbal? Yeah. Does he like? Could you get him to start looking at just labeling and just saying like certain feelings out? Maybe you could help pull. Well, I mean, like we talked about.
Or
like,
at bedtime.
Or that that part of that creating that bedtime routine type of thing, or that time where he gets those anxieties out. I know it will be a little tricky to do, but like,
It's a little tricky
yeah,
for the 4-year-old.
yeah,
He's verbal, but he's
yeah,
not a 2-year-old, so you can't really follow.
yeah. I totally understand that. Yeah.
So
Can't
Yeah,
either.
I just wanted to chime in. For my daughter, something that we do is like we have like pictures
Yeah,
or like a
pictures.
scale of like happy, sad, angry, frustrated, or just pictures of people, and she can still kind of like identify like where she's at. It's pretty reliable, I would say, because it matches like her behavior. So that might be just like a personal suggestion.
Just, I was going to mention that, yeah, too, just trying to find those scales, working at, like, with your other therapists, trying to create, communication boards or things like that to help, figure out those words to help, with those transitions. Yeah.
So I have some questions that kind of segue into, I think, kind of what we're talking about and a little bit more. There's a couple people that are asking about medications and what people should try and when. The person who asked first about the talking and the stimming in the middle of the night tried clonidine, and that did not work, and then tried trazodone, which has helped a little bit. So I think that's interesting based on your initial response. So I want to know what your thoughts are about that. And then the other question is, we've tried a few different medications and none of them have been working for staying asleep. So can you talk a little bit about your guys' experiences, either personally or professionally, with medication and what your recommendations are?
I don't have any, personally don't have, like, my daughter tends to, when she's asleep, she gets to sleep. But again, it was always a chore to get her to sleep. And then from the families that I work with, again, just trying to, it's routines and just trying to satiate those inner needs, trying to do those heavy work patterns and just removing a lot of the sort of that stimuli. But sometimes that doesn't always work either, though, too. So
Ryan,
Yeah.
can you speak personally if you've thought about medication for yourself? I don't know. Putting you on the spot.
Well, I don't
For
have the
yourself.
issue of falling asleep. Once I'm asleep, I'm asleep. But I'm going to say that once I got my sleep study and figured out, because I always thought I had sleep apnea, but once I found out that I have narcolepsy and got on my my medication, my world changed. It was so much clearer. It was actually very eye-opening on how much I was sort of missing out. So again, I hear you. It's sleep is such a very important thing, for overall development, for your mind and your body. So it's something to keep on working on. So yeah.
Yeah, I mean, that was so beautifully said. Thank you for sharing your own personal experience. I mean, like any disorder, there is a time and place for medication. There's a time and place when it's appropriate. And choosing which one, I think, is important because medications often have dual roles, multiple
Yes.
roles. Sometimes they have added benefits, sometimes they have side effects, sometimes those side effects are actually used to our benefit when we use them. So I think if you're struggling with your child's sleep or your sleep,
Yeah.
the first place to start is actually to talk with a sleep doctor, someone who's trained to think about specifically sleep in this age category. And one of the first things that I think a good sleep doctor will talk to you about specifically dedicated and directed therapies for insomnia if your child is having a hard time falling or staying asleep. That's not the same as sleep hygiene, right? Someone said it so beautifully. This is actually an adult sleep doctor out of Stanford, or I think the VA near Stanford. He said, sleep hygiene is like dental hygiene. It's what we do every single day. It's brushing your teeth, it's flossing, it's the stuff you do when everything is going fine. But when you are having a cavity, you're not going to be told to keep brushing your teeth. You're going to have a dedicated, directed therapy for that issue. There is something called CBTI, or cognitive behavioral therapy for insomnia, and it's a very specific set of techniques that's done with a sleep doctor, with really close follow-up, or a sleep psychologist, where you essentially shift the way the individual or the family is thinking about sleep while making specific sleep-directed changes, timing in bed, timing of the morning. But even with, dedicated behavioral therapy, sometimes there is a role for medication. One of the medications that you had mentioned, clonidine. There are other medications often used, things like guanfacine,
Yeah, that's what I was gonna
gabapentin.
say. My daughter's on guanfacine.
Yeah.
We mainly used it for attention, but then an offshoot was, but added benefit was probably the guanfacine helping with nighttime sleep. And I think I work with my neurologist, and we'll play with that dosage sometimes. And guanfacine is very, it's not a very invasive drug. It's actually pretty easy.
Right.
Yeah.
My daughter is also on guanfacine for attention-related
Yeah.
concerns, but it has, and our daughter can sleep when she falls asleep. It's the getting her to sleep.
Yeah.
And I mean, we've found that the behavioral strategies are really the most helpful. She's like 40 pounds soaking wet at 7, and my husband and I can put our entire body weight on her, and that's usually what helps her to calm down and go to bed. But yeah, anyway, sorry.
Yeah.
But when it comes to staying asleep, because like you mentioned, if your child isn't staying asleep, there are other differential diagnoses to consider that don't include insomnia. Things like periodic limb movements, or like a lot of restlessness waking them up. Things like sleep apnea waking them up. And so that's another time that it's important to seek out a sleep doctor, because it may be that your child benefits from an overnight sleep study. Sleep studies aren't this, I wish they did more. they tell us very, very concrete yes-no things about what's going on in the night, but those are sometimes helpful in informing what we do next. And the one thing I always hesitate to do is give a child medication to help them stay asleep when actually they're waking up because they're not breathing well,
Yeah.
right? I want them waking up then, and I want to address that underlying sleep disorder. I think the pandemic has led a lot of terrible things, but I think it's opened up a lot of sleep medicine professionals across the country who are offering telemedicine and offering consultations. And if you are in an area without a sleep medicine doctor, a pediatric trained sleep medicine doctor, then I think there's a whole array of people now seeing people virtually. And it's always helpful. Of course, I'm biased when I say this, but I think it's helpful to get sometimes a fresh pair of eyes.
I know, for me too, I have narcolepsy, but I also had restless leg. When you talked about how that sometimes will wake you up and things like that. Again, I thought I had sleep apnea, but it turned out the total opposite. So actually had a chemical imbalance for why I was falling asleep all the time.
Mm-hmm.
So.
And
Yeah.
actually, there was a mom in the front when you had asked about movement and a lot of movement and falling and staying asleep, right? That is sometimes how restless legs can present. And in that case, there's not only a role for medication, there's also a role for checking certain macronutrients. So that's where a pediatric sleep medicine doctor can really help.
This is a very specific question for probably Dr. Donskoy, but some medications like clonidine reduce REM sleep, but loss of sleep is also a risk. What's the balance?
Okay. So when we sleep in general, we have different stages of sleep. We fall into shallow sleep, then we enter deep sleep, and then we actually have dream or REM or rapid eye movement sleep. And then we kind of complete that sleep cycle, and after the age of 1, that sleep cycle is about 90 minutes long or an hour and a half. We know that certain medications can increase or decrease certain stages of sleep, but I think it's always important to weigh the cost benefit of, if this is going to help my child sleep overall more hours of the night, then I'm more willing to give up a certain distribution of a certain stage of sleep in order to get more overall sleep, because then throughout the night I'll actually have a pretty robust amount of all of my stages of sleep. So I personally, the truth is that deep sleep is far more important than REM sleep. I think people focus a lot on dream sleep because it's pretty cool that our brains can create these stories as dreams, but it's really deep sleep, or what's called N3 or slow wave sleep, that is the important one. That is where we grow. That's where our memories consolidate. That's where we have this clearance of even toxins from our brain in a manner called lymphatic clearance. So it's really deep sleep that is sort of the most important one. But what I would say is if we're choosing a medication, choose the medication that's going to help your child fall and stay asleep for the amount of sleep they need to feel great in the day.
I think that segues really nicely into the next question. How much sleep is actually needed? I have a 25-year-old son. He gets 10 plus hours of sleep, goes to sleep regardless or easy. He's rarely sleepy during the day or before bedtime. He's not on meds, exercises a lot, but he will also take a nap when we ask him to do so. So how much sleep do we need?
This is such a hot issue right now. Just last month, the American Heart Association actually came out with guidelines that now include total sleep times for children and what they need for health. The numbers that everyone seems to follow most closely are the National Sleep Foundation guidelines, which break it down by age, and they really give averages. So, for example, in an adult, well, I'm going to consider us adults here. We need on average 6 to 8 hours of sleep a night. Adolescents, which I may put that young man into, will generally need 8 to 10 hours of sleep a night. And then as we look at different age categories, those numbers shifts as well. I think it's really important to remember, though, that those are averages, and they're actually they weren't discovered by people putting children in the lab and really seeing how much they slept for and then testing them the next day to see how well they did in certain tasks. They're survey collected averages. And so there's a big bell curve of what's really normal. And there are also what we call short sleepers and long sleepers, kids without sleep disorders, adults without sleep disorders, who just need more or less than their age-matched counterparts. So this is the question I get asked most often anywhere I go when I tell people I work in sleep. But my general answer will be, if your child is falling asleep nicely and independently, staying asleep, and waking up feeling refreshed throughout the day, able to get everything done that they needed to do, the amount of sleep they need is the amount of sleep they're currently getting right now.
Interesting.
Awesome.
You talked about, like, it's funny, I was talking with someone about biphasic sleep.
Yeah. Oh, that's like a thing that sometimes people do too.
What is it?
Biphasic
Where you
sleep.
split.
Where you split your sleep.
Yeah.
That was just interesting to hear about, and I only know a couple people that do that.
Do you want to talk for a second about it or not really?
No, I mean,
Okay.
it was just leading up to like that talk of
Okay.
sleep, but it was
If
just.
if you're satisfied with your sleep and your health is going in the right direction, you're getting the right amount of sleep. But because you have narcolepsy,
Mhm.
I do want to say that if your child is getting an amount of sleep that is over, like significantly over the average, and they are having trouble making it through their day, and they're needing naps, and they're not able to participate in things that they want to participate in, they may actually have a disorder of hypersomnia or
Yeah.
too much sleepiness.
And that's what was happening with me, where I would be like all over the place. I couldn't keep myself centered, and then I would just fall asleep in the most inopportune times. It's a miracle that I made it through school, but but yeah, no, I think. But again, you talk about the quality of sleep. I think that's what I'm getting now. It's like I might get maybe 6 or 7, but really though, I think it's that quality of sleep is. I don't dream. I don't remember any of my dreams, but I do. I know on my sleep record, and when I do get a lot of deep sleep.
And you technically get dream sleep if you got diagnosed with narcolepsy.
You do. I
Yes.
don't remember.
You just don't
I
remember
just don't
them.
remember it, I guess.
All right, the next question is, my son only sleeps on his stomach, so sleep positions, doesn't matter.
I feel, once you're past a certain age, then it's okay. Obviously, we always promote, back to sleep. But again, if they're independently able to roll, they'll be able to, clear their airway and make it through the night. So I would suggest starting them out on their back, and then if, it depends on their milestones and where they're at. So, but again, once they're able to roll and lift that head up, I think it should be okay.
Agree with the one, sorry, I keep adding things, but with the one exception that they should be able to breathe well on their back or
Yeah.
laterally.
That's
So
right.
so if they're just choosing their tummy because it's more comfortable, as long as they're over one,
Mhm.
it's safe, right? But if you notice that they can only breathe comfortably on their stomach, and when they're on their back, they're snoring or mouth breathing or gasping or pausing in their breathing, then it's a concern that you see a sleep doctor for you.
Because I know, I think another thing that I always ask, the patients that I see is, like, I ask if they're snoring and that quality of sleep too, because I know sometimes enlarged tonsils and adenoids do affect that quality of sleep. So that's something to always talk to your physician about too.
So also another question. So we have a 13-year-old with poor attention and sleep for probably his whole life. We haven't seen a specialist in over 10 years to discuss this issue. Who do we see and what specialists do we see? And they are local in Chicago, so who would direct them to in this area? But I think that question comes up to a lot to me too. Do I see a developmental pediatrician? Do I see my regular pediatrician? Do I see the sleep medicine physicians? Do I see an OT? Do I see a behavioral person? Or do I just try some of the stuff that has been told to me already? So how do you guys navigate who should families go to first and in what direction they should consult?
Well, I always, I always get that question a lot though too, but I would probably, it always starts to me, I would direct it to your PCP, and then I would also make recommendations to see a developmental pediatrician. And then I would also recommend, again, like if you have all those 3 doctors in your areas, that's great. I would also, definitely consider, sleep, because I think just from my personal experience, how beneficial getting that diagnosed was definitely eye-opening. So yeah, I would definitely start in those avenues.
I think it takes a whole team. It takes a whole team to think about this together. And different pediatricians are more or less comfortable with certain topics. Different developmental pediatricians are more or less comfortable. So if you're feeling like you're having really good support, then you're in the right place. If you feel like there are things being unaddressed, that's when you ask if your team knows someone else to help with certain parts of what's going on.
Yeah, of course.
Yeah, when you say sleep doctor, like when I've gotten more for myself, there'd be like a psychologist or a sleep doctor who might say, okay, you have apnea. What do you mean for going to a sleep specialist, particularly when you're going for your child? Like, what direction would you start with?
So there are most academic institutions, I think these days, it's a newer specialty. I think there's only like 100 or so in the U.S. Then we need more of us. But there are people who go through usually pediatric training and then do an additional fellowship in sleep medicine, and then will sometimes do both adult and peds, and sometimes only practice pediatric sleep medicine. And kids' sleep is really different than adult sleep. It is. The sleep disorders are different. Their underlying causes are different. And so, at least in the Chicagoland area, we have Lori, UChicago, I think UIC, Advocate. We're fortunate that we are sort of oversaturated with pediatric sleep medicine doctors. But if you're looking for someone, you can go to the American Academy of Sleep Medicine website, the AASM website, and look for pediatric accredited institutions, physicians trained in pediatric sleep medicine, or pediatric sleep psychologists. And sometimes it's a matter of both working together hand in hand. Like Lori will have both, yeah.
We used to have one here too. And
She's ours, yeah.
So I've worked with her a lot though too. So.
Yeah, Allie Clark, yeah. So that's who I'm referring to. But it's not always, sometimes the team that you have is very knowledgeable about sleep if you bring up that those are the issues you're worried about the most. Is that helpful? Okay.
I think that's really key. I think Ryan and I talk about this all the time. There's so many issues that our kids face on a minute-to-minute basis. Even thinking back, I don't really bring up the sleep very much at my office visits with my doctor. So I think it's hard because there's so many things we're worried about and so many things we're addressing. So just remembering that you can go back and you can make appointments for different issues and kind of addressing them at each time and exploring that.
You know what, my neurologist has been for my daughter, has been really helpful though too. Again, this,
Neurology, absolutely.
yeah, you know, he has been very instrumental in, you know, advocating for us though too. So obviously, you know, with the seizure disorders, I think those are things that you could definitely talk to your neurologist about too.
I have a few more random things, but I wanted to see, we're getting close to time, if you guys had any just like narratives you wanted to share with the group or any other advice.
I would just suggest, like, again, you know, creating your own routines and just, you know, staying true to what works for you. I mean, again, you'll hear all these things all over the place, what works, but really it comes down to how your family lives and works. And again, you know, leaning into things, not getting so frustrated about stuff. That's even from a therapy, you know, from when you're working with your child, you know, like we always we believe in certain things, you know, how we see, but again, it's about balancing, it's about working, you know, I know your child may not be able to talk back to you, but it's about reading signs and being able to sort of compromise on those things. I think that's really, really important.
Absolutely. I think I'm like so humbled to speak to this group of amazing families and caregivers. I think there are no rules, right? I think we come in thinking there are all these rules about my child having a specific bedtime, and this is what a bedtime has to look like. These are the sort of things that have to be in the bed. When really the truth is I have kids who are, you know, nonverbal going to bed with their pads, right? With an electronic, even though the rules say no, because that's their way of communicating, right, before bedtime, right? And I have kiddos who prefer the hard surface of the floor than the bed, and that's just fine, right? It's what is going to help them feel calm and relaxed around the whole bed experience. There needs to be this really positive association between bedtime and my room and my bed and this space and how we communicate in this room. And, you know, speaking personally, I've had a share of bedtime stresses and elevated mood around bedtime when you kind of just need that evening to progress, but that's not what our kids need. Our kids need this almost fake it till you make it, very relaxed approach to bedtime to help them really put their day away and sort of settle down. And what that looks like family to family is completely different, and it should be, because our kids are completely different, and our kids are completely unique from one another. They shouldn't have these sort of cookie-cutter routines or even bedtimes. So I think going in with just that sort of peace of mind that if you're reading your child, you're doing it right, is going to already set the stage up for success.
I wanted to just share a little bit about my daughter's bedtime routine. And I stand here as a board-certified pediatrician that would never recommend these things as standard of care, but there's definitely screens involved. She's 7, and the only thing that shuts her down is a pacifier. She does not use a pacifier any other time of day, but to fall asleep, she needs to be sucking. And you know what? That is what we're going to continue to do until she gets rid of it. And I already told you, we basically almost lay on her. It's, you know, I mean, they talk about weight in OT as like 5% of your body weight would be like, I don't even know, less than 5 pounds. And we weigh like, I don't know, 10 times more than she does. So, or not 10 times, but 4 or 5 times more than she does maybe. So, you know, I mean, I think that works for us and we are not changing it. I mean, it is not what I recommend to any patients. It's not standard of care, but our kids fit their own box. So, you know, and it works for us. So I thought it was fitting to share. Any other last minute questions or anything? Okay, we are exactly on time. I am so proud of us. I'm going to give the mic back to Phil, and thank you so much to our amazing panel.
Thank you, guys.
Thank you all.